Welcome back to Rural Health Today and our latest series, Rural Health Fractured. In this series, we're discussing how rural health is being fractured in every direction by the politicization of health and science, the decline of resources for rural communities, deterioration of adequate insurance coverage, and yes, so much more. As we take a closer look at the fault lines in our healthcare system, our guest will provide new perspective on how healthcare leaders can navigate these challenges and explore sustainable solutions. Today, I am thrilled to be in the studio with today's special guest. And I have a privilege of introducing her, the founding director of Boston University Center on Emerging Infectious Diseases, Nahid Bhadelia. It is so great to have you for the first time in our studio. I'm excited about the opportunity to learn your story and to hear about some great things that are happening under your leadership. So, Dr. Bhadelia, would you please give us a short introduction about your role at Boston University Center? What is Emerging Infectious Diseases, and how long have you been there? What about your organization is so special, and why did you choose this field?
Ooh, all of that in maybe a minute.
2 seconds.
2 seconds.
Exactly.
Thank you for having me. And this is actually an issue that's close to my heart because, yes, I currently practice in urban setting, but while I was training and also as I do a lot of my global health engagement work, I actually have practiced in rural areas, both globally and also here in the U.S. I actually did locums tenens after my fellowship up in Colebrook, New Hampshire. So I've been a physician in the rural setting, and clearly not as much experience as our very talented physicians and healthcare workers currently in those areas, but it's been of great interest to me for that reason. So I am an infectious diseases physician, as you mentioned. I founded SEED, the Center on Emerging Infectious Diseases.
Oh, wow.
And have run it for about 5 years. It's a university-wide center at Boston University, and for a decade before that at BU, I was the medical director of a biocontainment care unit. So it's a specialized patient care unit that provides care to patients with highly communicable diseases like viral hemorrhagic fevers, like Ebola, etc., and has readiness for that. And I was the associate director of our maximum containment laboratory, the National Emerging Infectious Diseases Labs. And the reason I founded SEED, where a lot of my work under Needle was actually on the medical side, on preparedness side, working with our federal and state and local partners, and readying healthcare workers. And much of that was also global engagement. And so it felt the lab does very much translational and basic science, and just as COVID was rolling out, the impact of it, it became even more clear that what we needed was a dedicated center that worked on public health and policy research that can help guide our decision makers, our healthcare leaders, and that's what SEED does. What we do is what the tagline says, is research that powers action and policy. We do just-in-time research, what we call operational global health security, which basically means we try to answer real-world questions through evidence that we generate through our research so they can help decision makers put resources where they need to be.
How do you get your material out? In what mechanism and manner do you release your findings?
Well, being an academic center at a university, one of the main ways is through academic publications, but we don't stop there. SEED's entire purpose is to actually also be a community center where we can engage the communities around us. And so we have open public events, we have webinars, like we had one on H5N1, which was really well attended a couple of years ago, including many folks in the audience from rural areas. We have also, beyond that, we have materials we put on our social media channels. And lastly, we actually engage with legislative offices. Often we get outreach from legislative offices who want an answer to something, right? They say, tell me what the evidence is behind this so I can make sensible policy or suggest a sensible bill. So we do a lot of engagement in that way in terms of providing the current state of evidence as well as running the calculations or doing the work that may help a decision maker in that regard. And then one big program that I'm happy to talk about a little bit later as well is we have a public-facing infectious diseases surveillance platform called Biothreats Emergence Analysis and Communications Network, or Beacon, which many of the healthcare workers in your audience may already be familiar with, but if not, it's a free, open access outbreak surveillance platform where you can get situational awareness, and you can find it at beaconbio.org.
That's incredible. You know, Dr. Bhadelia, we are living in a time in which medicine is not often consulted by politicians. And it's got to be some challenging times for you. And we don't, we're not getting political. But the reality of it is that there seems to be a waning from science and an understanding of that. I just hope that some of the research and the work that you're doing will provide some breakthrough in our current administration, because there's definitely a significant need for it. So bless you in the efforts that you're taking at your center. We greatly appreciate it. You know, for someone that might be listening in Texas or Colorado, this is a national podcast. You've already said some great, incredible, interesting things about yourself, but is there something, that we could humanize you, an interesting, a fun fact about yourself that would resonate with our listeners?
Sure. When I read that question, I felt like it was a 2 lies and a truth, or 2 truths and a lie, or whatever that game is. But no, I'll give you, I will give you 3 truths. So actually, I'll give you 2 truths and the stories behind them. I am an avid photographer, and everywhere I travel for work, I take my camera. And so I actually went out to Missoula a long time ago for work, and took my camera out there, and I was out in Glacier National Park.
Wow.
And the guys at the outdoor store said, you have to take this bear spray. Out on the East Coast, we don't have that many bears. And I was like, really?
Right.
It's so heavy. They're like, no, just carry it. So I did, and lo and behold, I was like hiking, and from a distance ran into a grizzly. So I have a really nice photo, in which I went around touting to everybody, look, I have a photo of a grizzly. And they said, you're stupid. Why even from far away? Why were you waiting? But turns out many years later, I showed it to somebody who's from that area, and they're like, that's not a grizzly. That's a sugar bear. That's a cinnamon bear.
Something totally different than a grizzly bear.
Yeah, exactly. And
exactly.
The second thing is there's this stamp in Togo, the country, with my face on it. And
really?
Yes. Or I don't know if it's still in circulation. And the way that happened was in 2014, 2015, I was part of the global response to the West African Ebola epidemic. So I was deployed in Sierra Leone, and I took care of patients in Ebola treatment units. And then when I was back in the U.S., between my deployments, I did media engagement to talk about the emergency. And sounds like Togo employs a stamp creating agency somewhere in Europe that just popped my photo off the website, and now I'm on a stamp in Togo, which I actually have hung up in my office.
Well, I have some missionary friends from there, so I'm going to see if I can get one of these said stamps. So that's incredible.
You can find it probably on eBay,
Amazon or something.
Yeah, eBay 2014 Togo stamp Ebola.
All right, yeah. I'm gonna dig around for that. Well, that is an interesting and neat fact, but it really sheds light on the personality of who you are in the work that you're doing, and to go into foreign places to be able to make a difference. It just speaks volumes of the type of person you are. So thank you for sharing your time with us today. We're going to jump into some questions. And for our listeners today, we're going to be talking about infectious disease management in a rural healthcare setting, because it does look much different in rural America, as we know. Access to infectious disease is very difficult to find. You're traveling longer distances. Transportation becomes a concern. You can't get there. Consultation with primary care becomes non-existent in rural communities. We're facing that right here at Hillsdale Hospital. Been recruiting infectious disease for probably 3 years now. Cannot locate, find, or identify anyone interested. But today we're here with a leading expert. Dr. Bhadelia is going to share her perspective and insight as an infectious disease physician. We'll talk about the role hospitals play in infectious disease overall, the prevention, the public trust in healthcare authorities, and of course, what all this has to do with rural health. So let's just jump right into some of the questions today, if we could. When controlling or preventing the spread of infectious disease, which is what we're engaged in public health, what would you say are the unique challenges that the rural communities face that maybe not necessarily urban centers are facing? Could you give us, lay the foundation? What are the challenges?
Sure. And maybe I'll move from the middle out. I'll
Okay,
start with the infectious diseases themselves.
great.
So you asked me at the very beginning what emerging infectious diseases are. So we actually focus on emerging and re-emerging infectious disease, which means new diseases or those we previously had control over that are now coming back and are posing a threat. And when you look at the last 40 years, the new diseases that we've faced are, most of them, about two-thirds of them, are zoonoses, which means they are diseases that jump from animals into humans. And it's a combination of diseases jumping from wild animals into domestic animals jumping into humans, or it might be, right, it might be circulating straight from wild animals into humans. And now you can already see that then this poses a particular risk for those communities that live, farming communities that live around domestic and peri-domestic animals, more so than a lot of urban communities may. Although I think it's a different profile in the urban setting. So when you look at diseases like avian influenza H5N1, if your listeners may remember from a couple of years when we had potential risk to farmers, dairy farmers, that's
Yes.
an example of a potential spillover type of disease that might impact rural communities. Another one is New World screwworm, which is an evolving threat that is a threat really more to agriculture, and to more rural areas. But because you may see it also in animals, but you can actually see human cases, and we actually had an imported human case about last summer or so in the U.S. From
Hmm.
Latin America, and it's one of concern because it's moving up from Central America, and there's a concern about the impact on the U.S. industry, agricultural industry. So then moving out from that, I think it's the patients themselves, the vulnerabilities that you talked about before we get to the health systems part. But because of lack of easy access to primary care, you can see that you may have greater vulnerability, so that if an infectious disease evolves, it may take longer to seek care.
Hmm.
And bacterial infections in particular move very fast, and not being able to access antibiotics, you might move to sepsis and septic shock a lot more faster. um, and then it's the system itself, and you alluded to it, and it's actually interesting. I went back because I look up these numbers every few years, and it gets worse every time I look it up.
Hmm.
um, so the latest numbers, from what I understand, is we've seen like the population, physician to population ratio is about 40 to 100,000 in rural areas compared to 130 in urban areas right now. And you talked about specialists in particular, like me, the ID specialists, and others, about 30 specialists per 100,000 compared to 263 in urban areas. So if you have more complicated or unknown emerging infectious diseases, you can see why this would be a lot more complicated, even if patients were able to get to care.
Hmm.
And then it's the access to the care itself. I mean, I think everybody, I'm sure other guests have talked on your show about the closures of many of the rural hospitals, which
Yes,
increases the distance, right?
sure does.
And beyond that, I mean, not just the ones that have closed, but an additional large number, twice as large, is, so I think it was 180 that have closed since 2010, and 400 more are considered vulnerable, particularly now, to closure.
Hmm.
And then lastly is the Medicaid expansion issue, which is
Yes.
Medicaid makes up about, I think it makes up about 36% of the coverage. It's the primary insurer, if you remember correctly, of rural America. I think.
Hmm. Hmm.
Let me just confirm that.
I
It's
can
about,
tell you
yeah,
from our
14%.
perspective,
Yeah.
yeah, it is. It is. Yeah.
Yeah, so
Exactly.
14% of rural America is uninsured compared to about
Yes.
10% in urban areas. And
Correct.
then Medicaid is the dominant
It's a
insurer in those
dominant. It's
areas.
a dominant.
It's the dominant insurer in
Yes.
rural areas, covering a large share of working adults, right? And then you
Yes.
have older adults who are in Medicare. So
Medicare.
this matters because many of the rural communities, particularly in the South, the states did not apply for Medicaid expansion.
Correct.
So the services are fewer to those communities because of that. So there's all of that, and then there is, if there's fewer beds in hospitals and doctors to begin with, then you
There is.
prepare for your everyday work. What you don't prepare for is a potential surge. So if you have an outbreak,
Hmm.
can you really shut off the strokes and the heart attacks and everything else
Nope.
that's going on? So the
No.
lack of ability to surge is a major rural, both an issue in rural areas, but also in the urban areas, but rural areas in particular, because where do you send people when the problem gets bigger?
Yeah. So, very interesting, and we address it on this podcast often, but it's the public policy piece that's happening in Washington and the impact on our rural communities. When H.R. 1 was put into place, and by 2032, the devastating impact to rural communities like mine are a reduction of $6 million right now. From the revenue that Hillsdale Hospital is already operating on zero margin. How do you serve that population when 72% of my payer mix is the government? And so public policy and what is happening in the corridors in Washington has a dramatic impact on individuals' ability to get the care they need. And in rural communities, it is the majority of the population on government payers. And so to your point, these are all very, very challenging factors that contribute to this problem. And until we have a population that's willing to rise up against that, to say we are not going to allow these programs to be disrupted, it's going to continue, and we're going to see larger and larger challenges and outbreaks. And let's talk a little bit about that, because there's been a lot of public policy changes, a lot of debate. There's been a considerable amount of
and maybe more to come.
And
Scary.
many more to come. It is. You're hearing some of the most ridiculously policy changes that we've ever heard of.
Affordable Care Act, potentially being affected. Yep.
Absolutely. And you have individuals who not only now are going to lose their insurance through Medicaid coverage under the nomenclature of waste, fraud, and abuse, which we know doesn't exist in the context that they're trying to paint it. And then you have the ACA tax credits, which roll back, placing people at higher risk of not seeking and obtaining the treatment that they need the most. And so I guess, would you say from your perspective, you've studied it, you've looked at it, you're working in public health, is there a correlation between shifting public trust, which we've watched happen in the last several years, in healthcare authorities, and the recent uptick in the infectious disease outbreaks that we've experienced?
I mean, absolutely. And it's not just a recent issue, right? I feel like there's been a continual erosion, and I think it's partly for many reasons that we can talk about in a little bit. But I want to use an example not in the U.S. because I think it congeals the idea for the U.S. I talked about how I was involved in the Ebola response, and it was in Sierra Leone was a country that's conflict-ridden, and they had a really bloody civil war a decade or so before the Ebola outbreak happened, and there was so much distrust in government sources and foreigners, and here we are setting up these tarp tents and containment centers to try to bring people in for isolation. And in 60% of the cases, because the mortality from the disease, particularly in the resource-limited setting, can be high, their loved ones wouldn't come out. Imagine the distrust, right, of people to say, well, this person looked like they had malaria, and then you're telling me Ebola, during the West African Ebola epidemic, it was the first time Ebola had appeared in Sierra Leone. So they're questioning, why does I need to worry about this, a disease that I've never seen, and now you're telling me it's something I need to be concerned about? Yeah. And then you're taking my family member, and I don't see them, and so people stop bringing their loved ones to care, which spread disease. They stop wanting to bring somebody who passed away in their homes. People are most contagious when somebody passes away with Ebola. Yes. So why does this matter? So when you hear that example, you're like, oh my God, why don't they have a better understanding? Of course they should bring people to care, right? I want to now put a juxtaposition. Measles in the U.S., right? You've had an erosion of trust. The number of people who think childhood vaccinations are important and critical is decreasing. You've seen a drop in vaccinations of kids as part of exemptions. Many of the states have actually made it easier to potentially get exemptions. And you have a drop, which then takes the population immunity down from what we need it to be, which is above 95%. U.S. is now seeing over 2,200 cases in 2025, and we're already over 1,200 or so this year, and it's only March, and we're about to lose our elimination status. We eliminated this disease, decades ago, and so many physicians, many patients, and parents haven't seen it. And now, on the other hand, they're hearing all this disinformation about vaccines. So they're saying, I've never seen this disease. Everybody
Yep.
I know, who tells me anything about measles tells me I don't need to worry about it. Why do I need
Yep.
to bring my child to care?
Yep.
I'm
Yep.
just going to keep
Yep.
them, and I'm going to put them together in a party like we do with chickenpox, which also you should not do. You should get the varicella vaccine. It's better for
Right.
the kids.
Right.
A chickenpox vaccine rather. And so um, you can see how distrust in not just greater public health but also science
Mm-hmm.
about, and even distrust about infections and what public health authorities are telling you can
Mm-hmm.
directly lead to expansion in both of these stories in infectious diseases.
Man, what a beautiful analogy to demonstrate how this shift has occurred in this country. We here face the same challenges in rural Hillsdale County. I just had someone last week argue with me about how vaccinations cause autism because they watched a TikTok video. Swear to goodness, they watched a TikTok video. And we face more and more of that. The clinicians are challenged with, I Googled it and I think I've got X, Y, and Z. And they're facing that. But there's a whole new segment, kind of like a subculture that's going on in this country right now, which is teaching and lambasting our households with ideas that these preventative measures are in and of themselves causing a greater a crisis in this country, and that is farthest from the truth of what we know to be exact when we rely on science. So my question to you is, we talk about this through the lens of health literacy, right? And as we look at that, how does health literacy impact the spread of infectious disease in rural communities? Because there seems to be some challenges here.
Yeah, let me start by saying I also think that I think there's two types of health literacy. There's the literacy of like, what do I need to do for my own health and what's best for me. And there's the literacy on how to navigate the healthcare system.
Yes.
And those are both becoming more and more difficult for people to navigate. Yeah,
they are.
And I think there are challenges for both in rural areas. And for the first one, I think this too is kind of tied to a lot of macro level dynamics, right? A lot of local. I think it's a quarter of the local newspapers in the country have closed down since 2005, and I believe it's going to go up to like 1/3, in the next year or so. And then you have where do people get their information, right? So many of them may not have good broadband internet, in particularly in rural areas, although the access to that is improving. So you listen to your peer network, or you listen to your religious leaders, and and so you may not be able to, access all the channels, only the ones that are available. Ability to access authoritative health information is partly dampened due to people's locations in more rural areas that are structurally affected, right? And that means that the sources of information are then skewed to the kind of things you're talking about beyond the social media and TikTok and things like that. It's also peer networks, and if they're all part of the same Facebook group, or they're part of the same community, and that is the dominant strategy, which is why we actually but it's actually a bit more complicated than that too. I want to challenge our thinking a little bit. We did this. My center did a annotated bibliography on trust in public health communications, and you can find it on our website under publications somewhere. And what they did was they, after COVID, put together an entire list of all the best evidence that's available in terms of how to engage with people. And there was nothing surprising in there. But what's important is when you look at it all put together, the same themes come out. And it's actually the same themes we've seen in other infectious diseases challenges too, like polio eradication. Global polio eradication. One of the seminal papers that they've talked about in terms of what's important. Same thing with Ebola, in Democratic Republic of Congo and other places. The key thing that people say is that you can't just be concerned about the diseases you're concerned about. That you need to be present in a community for a long period of time and have a longitudinal contact with them to create that trust. So part of the reason I believe rural communities also don't have as much trust is who's their contact to public health? Like, public health is debilitated even in big cities in terms of number of workers and things like that, right? And so what is their face for a public health worker? those don't exist. So you don't have a continuous connection with somebody. And not only that, but I think that they're not seeing the gains in terms of
Correct.
healthcare that people that are more resource rich are seeing in this country, where that continuous sort of connection to tell you this is the messaging, this is what we're thinking, this is why we're doing it. And we're not just here for this one disease, we're here for everything
Hmm.
that matters to you. And if their health is suffering from many different things, why would they be concerned about vaccines, a
Hmm.
thing that could happen in the future when all these other medical problems are going on today? And so I kind of feel like regaining trust in some ways is
Yeah.
actually structural beyond just telling people learn the good information, although that is
Right.
important.
And I think you would submit that it's going to take a lot of work.
It's going to take
Uh,
a lot of work.
I mean, it's exhausting, that we are in healthcare to save lives and to a certain extent, to educate, our communities about the risk associated with certain things, whether it's disease or infectious disease, and yet we're just absolutely sidestepped by this notion that chat groups and politicians know better. And I think that the biggest challenge that we're going to face, you and I, as we try to set forth the truth, is how do you marginalize that? And I know we're not going to be able to answer that today, but for my CEO friends who are listening across the country, who are battling just like I am in my community, many groups have risen up to say no vaccine for our children. Many groups have said, for all of their own ideologies and reasons about why they feel others shouldn't be vaccinated either. How do hospitals and healthcare leaders better prepare our communities to manage these now? What advice would you give to someone? Maybe they're just, where do I start?
Yeah, it's oh boy.
I know,
Where do you
I
start?
know.
Well, let me start with where you started, which is what can healthcare leaders do and hospital leaders do? And when you look at surveys, they still, surveys still say that Americans listen to their doctors, their nurses, their healthcare workers, right? And I'm sorry to say, we don't do nearly enough education in medical education and in nursing education to really to be able to do communications education
Hmm.
for clinicians. I
Hmm.
think it's a structural problem. So one way to start is how to equip our clinicians who are going to be in the room with the patients, and they
Hmm.
will be that long-term connection. I mean, you don't maybe there's not enough public health workers, but the healthcare workers are in essence public health workers and healthcare workers. So how do we how do we arm them with better techniques to be able to talk to their patients? And that's one way. The second is, when it comes particularly to the kind of diseases that I'm talking about, emerging infectious diseases, novel
Right.
pathogens. Um, One of the major things that, I ran a biocontainment care unit for like 10 years, and there are actually a whole network of these around the country. One of the key differences about those versus maybe more rural communities, secondary and, primary healthcare centers is that there's not as much training for healthcare workers to feel comfortable in taking care of these patients. And so focusing on how to make healthcare workers feel comfortable and protected if they find a patient who might have a disease, right? That can help quickly isolate the patient, identify them, and keep healthcare workers safe. And so that requires actually commitment and resources to be able to take that time and be able to give
Hmm.
healthcare workers that training. And the
Hmm.
last thing is situational awareness. Are there better ways? Departments of health certainly do this, and
Hmm.
that's why one of the reasons we generated Beacon, which I talked about at the very beginning, was to be this open platform. So if someone comes into your emergency room, you can say, okay, they came from this country. What are the outbreaks going on in that country I need to
Hmm.
worry about? But beyond that, it's actually a resource for public health workers in rural settings and in every community around the world. We have actually users in over 200 countries and territories already. We started about 10 months ago. We are integrated into WHO's platform that's open to 120 ministries of health and public health organizations. And what we find is actually a lot of different types of users who reach out to us, who use it for different purposes, right? I had an emergency room doctor reach out the other day with suggestions on what would help him even more, if we were to use
Mm-hmm.
this. So other resources, sure Beacon, but other resources for situational awareness to allow healthcare systems to be more ready. Those are things specific to my domain that I can talk about.
Yeah, there's also, so specific to your domain, but there's also opportunities, I feel. The most trusted profession right now, we're told, is nursing.
Mm-hmm.
Let's deploy our nurses. If you're
Mm-hmm.
listening as a CEO across this country, I think there's a great opportunity for the public to have trust of nurses. We see it statistically, it's proven that they're one of the most highly trusted. Let's leverage that and have our nurses begin to help educate our respective communities. These are the nurses that are going to church together. These are the nurses that go into the social clubs and have conversations. We need to empower them and give them the support and tools they need to be able to carry that message forward. It's not propaganda, it's science, it's proven, we know it works. How do we get there is going to be some of the challenges.
Yeah, and I wanted to stress what I said, which is that I don't think it's just the doctors. I think in general, medical clinical education
Right.
doesn't do a good job. It covers the facts, it doesn't do a good job
You're
of
right.
communication strategy.
That's right.
And honestly, that is what, nurses may know all the science behind it, but they may not want to get into a standoff with somebody in the church,
Right.
right? So what are
Right.
the communications techniques to softly introduce, right, potential
Yeah.
ideas about science and to dispel mis and disinformation? And I think equipping them with that and giving them facts that are current, they're today, that they can answer and counteract disinformation that people are hearing, like autism, right, which has been disproven so many times. Hundreds of thousands of
Yeah.
data points now
Yeah.
at this point. Tons of studies have shown it. And it still circulates, right? And so, what are the most recent talking points? Mercury. I mean, we don't use that,
Right.
right?
Right.
Like
Right.
it's just what are the talking points that they can specifically dispel? That's important, I think.
Absolutely. Can you give us, and I'm going to go off script for just a minute. Can you give us maybe something that's exciting to you that you're working on right now that you're just like, this is great. I feel great about this, and maybe share
Yeah,
it with our listeners.
yeah. So my center is doing this FIFA World Cup intelligence project. I There are actually, not I'm not quite in rural settings, but Kansas and Texas both have
Sure.
sites in addition to, right, the East Coast, West Coast, Central, and we're working with many of the departments of health in sites that are part of FIFA, as well as if we're in communications with CDC to create risk assessments from an
Hmm.
infectious diseases perspective that gives situational reports. And we have this whole army of experts who are behind this project, and we're just very excited to be able to do this. And I think we're gonna, if people are on our website, you can see an example of what we've done with other mass gatherings to a much lower level. With Olympics, we did that. We actually gave a
Hmm.
background of who's coming together, what are the circulating diseases, what diseases could you see based on what we've seen historically. And we,
Hmm.
we actually, for Olympics, we did it. And then we sat back and we're like, well, we're not going to see anything. It's in like northern Italy. And the next
Yeah.
day, there was like a norovirus outbreak
Yeah.
in the Finnish hockey team, right?
Yeah.
So there's
Amazing.
a whole
Yeah.
list of outbreaks that
Sure.
we listed during that as well. And we anticipate there might be biological events that we
Yeah.
report in addition to the risk assessment project that we're doing through the center itself.
Yeah. So we're going to put in the show notes how you can, your information and how individuals can reach out to you, contact you, and read more about the work that you're doing. The last question I want to ask you is, what's keeping you up at night? What concerns you the most in the work that you're doing, where you're just really worried?
Well, we talked about one of the main ones, which is this losing battles we've already won. And good God, I now hear people talking about polio vaccines and do we
Yes,
really need it? And it
I know.
just petrifies me, because are we now going to see polio
I
outbreaks?
hear it. I hear
You
it
know,
often.
and then beyond that, I mean, there are nature serves up a lot of surprises, and the emerging pathogens that we've seen. You want to say COVID was once in a century pandemic, and I really hope it was. I
Hopefully.
don't want to face another one. But
No, no
we
one
will
does.
certainly face epidemics that are regional.
We sure will.
We will see big threats, and the scariest of those is that you know us not investing in infectious diseases, which has
Hmm.
been proposed by politicians. Us not preparing for pandemics or for biodefense in particular is very scary because biotechnology and synthetic biology is in a place
Mm-hmm.
where, our smallpox the biodefense strategy, for example, is built around the idea that smallpox exists in two places, right? There's two labs that have it, and then we have the pandemic preparedness, and we have all the vaccine positioning and diagnostics. It is probably not that far in the future that synthetic biology will make it possible for other actors to be able to
Yeah,
produce smallpox like particles and
clearly.
release it
Clearly.
anywhere,
That's right.
including rural areas potentially, right?
Yes.
And the idea that we will put our head in the ground and
Yes.
not prepare for that is very scary to me.
It's unimaginable. Let's just leave it right there. There has to be a change in the direction that we're headed. But that happens because our listeners lift their voice in rural communities across this country and say what is most important to them. They do not need nor want to manage these type of outbreaks in their rural and respective communities. So if you're listening today, you can be a voice. Join with your public health officials. Join in the great cause that Dr. Bhadelia is working on, and you have a voice, and you have to lift that voice. So, you know what? It's been great to have you on the podcast today. Our time has escaped us. I do have one last question for you. We like to wrap up our Fractured series with just a question to our guest, and that is, for someone listening today who may be new to healthcare, to public health in general, what recommendation would you give them? It's a very discouraging time right now.
Yeah.
It's a time in which people are exiting the industry, going into other professions. CEOs are retiring at unprecedented rates. What sage advice would you give to someone listening today about how to keep on keeping on?
Oof. I think we're so much more globally connected, even though we have these silos of information that we've talked about. It is now possible more than ever to see when someone else is suffering somewhere else.
It's true.
And I want to hold off, I want to hold the hope that if we get better at sharing the results of some of the actions, political actions or individual actions, right, around infectious diseases, that people will change their mind. That people are inherently good, and maybe that's what keeps me happy to get through the day, to
Yes.
keep doing what I'm doing.
It's fantastic. Great suggestion. Continue keeping on. It is a fight worth fighting. And I can say this with all comfort and ease. History will judge us, and I believe we're on the right side of history.
Yep.
As long as we
No
continue
doubt
to lift
about
our voice.
that, right?
Absolutely. And
Yeah.
we're lifting our voice, and we've got to continue to do it, even in the midst of the storm. So thank you so much, Dr. Bhadelia, for being with us today, for sharing your perspective, for the passion that you have for impacting communities, and ultimately for saving lives. It's been great to have you on the podcast today, and we want to thank you, first of all, and we want to thank our listeners who tune in each week to listen to Rural Health Today. I'd encourage you to catch our next segment, Rural Health News. Stay up to date on the current state of rural health every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources at Rural Health Today at ruralhealthtoday.com, and make sure you subscribe so you never miss an episode. Until then, remember, rural health strong.